Dr. Desai. For stage 4 non-small cell lung cancer with high PD-L1, but a atypical mutation, let's say, EGFR that's not described or a VUS, would you, or maybe a point RET fusion, I'm just throwing out some specifics to try to flesh out this question. Would you favor targeted therapy for not perfectly defined, but still gene-relevant directed therapy? Would you favor chemo alone? Would you favor chemo IO? Or how do you think about those mutations that don't quite fit into the clinical trial schema for what we're enrolled, but could potentially be sensitizing?
Yeah, I think that's a great question. I mean, I would probably consider it, but only in later lines of therapy. If I have more definitive evidence with a high PD-L1 to go with the immunotherapy backbone, I think I would probably go with that. And also, it depends on case-by-case basis. I can envision that, you may have issues with reimbursement if you're trying to use a targeted therapy, which is kind of outside the scope of approval without any good evidence, even in other studies, even if it's not FDA approved. So I would probably approach it with an immunotherapy backbone, with the fact that there may be, when we go to the second and third line and we're kind of having to find options, I think then definitely something, if at that stage it makes sense in terms of tolerability and, with the disease burden and things, I think then maybe, willing to try that targeted therapy.